have participated in over 50 clinical trials. His present research interests are tocotrinols and magnetic resonance imaging. Dr. Magosso?
Thank you very much, Mr. David, for the kind introduction. I'm sorry to spoil your lunch because talking about fatty liver, so later we'll look at your food in a different way. So the topic of my talk is actually what you can do with tocotrinols for a healthy liver. So the outline will be an introduction on the non-alcoholic fatty liver, the natural history and the epidemiology, the management and the proposed treatment, and finally the tocotrinols for non-alcoholic fatty liver, what the tocotrinols can do. So let's start with the definition of non-alcoholic fatty liver, or most simply NAFLD. First of all, it's not a single disease, but it's a group of diseases which they consist in a fat deposition in the liver in absence of excessive alcohol intake. That's why it's non-alcoholic. From a pathological point of view, alcoholic and non-alcoholic fatty liver actually are the same. That's why early misconception about the non-alcoholic fatty liver. What is known now is they actually represent the hepatic component of the metabolic syndrome. What we don't know is the actual way it develops, so we don't fully understand the pathogenesis of this disease. What we know is actually there's not yet a proven pharmacological approach, and that we cannot detect from simple blood test. So the ALT, AST of your blood test are not sufficient. So at the beginning, actually, non-alcoholic fatty liver is asymptomatic, so you don't know you have it. And it's only suspected when the liver function test is inexplicably high. So that's why the term cryptogenic, when they don't know where it comes from. We only confirm with the ultrasound, magnetic resonance, or biopsy, a more advanced stage biopsy. Usually CT scan is no use due to the radiation. What we know about the natural history, this one we know. Basically, we start with an underlying patient condition. So there is overall a dietary and lifestyle imbalance. So a diet rich in fat and sugar, not just fat, and excessive carbohydrate intake in general. What was found a few years back, actually the patient with non-alcoholic fatty liver actually have a lower than recommended intake in vitamin E, in particular in the non-alcoholic steatohepatitis, which is the most advanced stage of non-alcoholic fatty liver. And these patients tend to have a sedentary lifestyle. The theory behind the development of fatty liver is a so-called two hits theory by Professor Day. It basically consists of a first hit, which is this metabolic imbalance that we just mentioned. So this which results in a high fasting glucose, insulin resistance, and diabetes ultimately, and obesity, in particular abdominal obesity. This one leads to a primary hepatic steatosis, so primary deposition of fat in form of triglyceride in the liver. Then we have a second hit. So at this point, the insulin resistance is established. We have an increased oxidative stress and lipid peroxidation, so we have a reactive oxygen species present. We have an increase in tumor necrosis factor alpha and a reduced release of adiponectin and increased release of interleukin 4 and 6 in particular, which are profibrogenic. So this one we'll see later will lead to the fibrosis stage. And this one leads actually to a low level of chronic inflammation for the patient and ballooning of the hepatocells and necrosis. So this one is already advanced stages, so-called non-alcoholic steatohepatitis. So what happened from simple steatosis or simple deposition of fat in the liver, only a minority, less than 50%, will develop a more severe steatohepatitis. And actually this, this development, excuse me, this development actually takes time. But once the steatohepatitis starts, then there's a fast process to go to fibrosis and subsequently the risk of cirrhosis. When we have cirrhosis, established cirrhosis, or cryptogenic cirrhosis for non-alcoholic fatty liver, we have actually many of these patients will have a liver failure. In fact, up to 80% of them will require a liver transplant. This is, in fact, what we say about the non-alcoholic fatty liver is will be the major cause of liver transplant in the near future. Another path, once you have cirrhosis established in this patient, is that will lead to liver cancer, hepatocellular carcinoma. However, steatosis, actually, in the majority of cases, the patient with steatosis will die of a cardiovascular-related death. This was a recent paper a few weeks ago. It was actually, they were revisiting the data of the NANEST, which is the National Health Survey in the US. It involved about 7,000 people. And they noticed that individuals that have fatty liver, when they have an associated metabolic disease, so diabetes, hyperlipidemia, or hypertension, high blood pressure, and so on, they tend to have higher mortality risk than if you have a simple fatty liver. This was published a few months ago. In fact, when we go and see the data, basically there's no difference in the survival curve of patient with or without, with fatty liver or without fatty liver if they don't have a metabolic syndrome associated disease. Not even for liver-related specific mortality. But when considered a patient with at least one metabolic syndrome-related disease, the mortality rate is significantly higher. So, as we said, the major risk factor, dyslipidemia, diabetes, and obesity. So basically, you have to keep in mind that these are the diseases that are actually causing a pandemic worldwide, on the rise. How about fatty liver in particular is considered the most common non-communicable liver disease in the world, is particularly in the industrialized world. We think about 10 to 30% of the adult population, general population, so not specific, they're estimated to have some form of fatty liver. So this one gives you the number for the industry people in particular. How many people in the world may have a certain degrees of fatty liver. I don't want to go in the details of these slides, but just to show you that there is a difference between type 1 and type 2 diabetes. So patients with type 1 diabetes are less likely to have non-alcoholic fatty liver, only 24%, compared to 80% in case of type 2 diabetes. Another important thing is that the higher the number of metabolic syndrome disease related disease you have in your patient, the higher is the incidence of prevalence of fatty liver in this population. I'm sorry. But what happened in Asia? Well, recently, this is a few months ago, came out this review paper from Nature that actually established the fact that Asia is not immune. It's just underestimated, basically. They found out that it's actually as important as in the West. In Malaysia, it's particularly underestimated, though. There are only 2 studies so far. One of is ours, actually. One is in a liver patient. It shows that there are more cases of severe fatty liver, so non-alcoholic steatohepatitis. But when we go to a normal population with a risk factor, with hypercholesterolemia as a risk factor, we see the number is fatty liver, which is detected on ultrasound, is about 60%. So it's very high in this case. Unfortunately, this is actually is a banner from is a program of the gastropathology conference. We had to create awareness also among the medical fraternity, because they're wondering what is fatty liver at this stage when it's very well established in the West. Now we move forward to the management of simple steatosis. Basically, the most logical approach to non-alcoholic fatty liver treatment is actually to tackle the associated condition. So increase your active lifestyle and treat the metabolic syndrome-related comorbidities, so insulin resistance, diabetes, and obesity. These are actually the guidelines about the WHO. But when we go to non-alcoholic steatohepatitis, which is the most severe case, the guidelines, they don't change so much, in the sense that treat as a simple steatosis, mostly follow up for hepatocellular carcinoma, and use therapeutic agents which are not established yet. So many studies have been done on potential treating agent. So insulin sensitizing agents, or oral antidiabetics have been tested, lipid lowering drugs, so the statins basically, many hepatoprotective agents, so also desoxycholic, betaine, you mentioned, everything has been tested. Even combination, like for example, pioglitazone and vitamin E. So vitamin E, well, yes, vitamin E, as the Americans say, is only alpha tocopherol. The latest, the previous study, they started about 2000, the first study, and actually they were a bit controversial. The results were not consistent. Many studies, the results not consistent, until the PINC study, which is this one, that was done, concluded a few years back, in which was proven that vitamin E improved the ALT, improved histology, and improved the inflammation, but did not improve fibrosis. However, the tonic study, which is almost just subsequent to the PINC study, but was done in younger people, in youngsters, shows contradicting results once again. So the summary of the PINC study, which is the base of the vitamin E for non-alcoholic fatty liver, is actually on 250 patients almost, randomized either to pioglitazone or vitamin E, high dose of vitamin E, 800 milligrams, 800 units. And the primary endpoint was a reduction of at least 2 points in non-alcoholic steatohepatitis score, and no increase in fibrosis, so no progression of the disease. So the results show that only vitamin E showed a reduction in the ballooning, but none of the, no pioglitazone, no vitamin E, show reduction in fibrosis. So nevertheless, last year, the American Association of Study of the Liver Disease, which I'm a member of, and the American Gastroenterological Association came out with this combined statement that vitamin E should be used for non-alcoholic steatohepatitis, but there is a but. So it must be limited to non-alcoholic steatohepatitis, which must be proven by histology. The patient must not be diabetic, and they should be given a high dose, which is 800 units. For how long? This is a good question, because the study showed that until 96 weeks. But then when they suspended vitamin E, the ALT rebound to pre-dosing level, to baseline level. So the summary of the PINC study was an improvement in the group treated with vitamin E, 42% versus 19% placebo. Keep in mind this data, that's why I put the reminder. The concerns about the vitamin E, we all know, and the recommendation given by the ASLD and the AGA are now known. So why tocotrienols? Well, we know the literature is well known in literature that tocotrienols are up to 60 times more potent antioxidant against liver microsomal lipid peroxidation, which is actually our target. We know the tocotrienols have higher affinity for alpha-TTP. We know the liver is a preferential site for biodistribution for tocotrienols. We know from, oh, actually this is very, more than 20 years, that tocotrienols reduce the liver neoplastic lesion in animals treated with the acetaminophen, which is a cancer-causing agent. We also know that there is they cause less hepatic triglyceride accumulation in animals treated with the CCl4, which is a carbon tetrachloride. They reduce ALT activity, which is one of the liver function tests, and especially gamma-tocotrienol was reported. We know that actually, these are all recent papers. The last one was actually quoted by the previous speaker. There is less hepatic triglyceride accumulation in animals and in rats and in the HepG2 cells when they treated with tocotrienols. We also know from this recent paper that tocotrienols, in particular gamma, may regulate fatty acid synthase and carnitine palmitoyl transferase, and tocotrienol may reduce hepatic inflammation and endoplasmic reticular stress. So we did a study. Actually, we did the study before all these papers were published. We used a more natural approach. So we fed our animals ad libitum with a very high fat and fructose diet, standard diet, or fat and high fat and high fructose diet with tocotrienols added. And we determined the amount of tocotrienols they accumulate in the liver. Okay. This is a table just to show that tocotrienols did not prevent the animal to become obese because the weight of the animal treated with the high fat, high sugar was about the same than the one treated with the same diet with tocotrienols. Also, the liver size not much different. What was different? It was the histology. This is a control, so it's a normal, and on the side, as you see, is the steatogenic diet. So you see it's the steatosis, steatohepatitis, you see the ballooning, the fat deposition. But what happened to the animal treated with the same diet that caused this liver damage when we added tocotrienols to their diet? Just a word. We fed the animal the same equivalent dose of 400 milligrams per day that we fed to humans. The results are actually very nice because the liver looked perfectly normal. So this is after 6 months of treatment. In conclusion, all animals that were fed the steatogenic diet actually developed fatty liver, and no animal fed the tocotrienols with the same fatty diet developed fatty liver. This is actually very good for us. As we always say, this is good, this is animal, this is cells, but in humans works or not? Well, we did the humans. So we were actually retrospectively, we did the human study first, and then we noticed that it worked. So the aim of the study was actually the amelioration of non-alcoholic fatty liver grading on ultrasound. We used the female patient, male and female patient, adults, 35 years and above, with the hypercholesterolemia as a common risk factor. And they did not have any advanced non-alcoholic fatty liver, so clinically not advanced. We measure the plasma levels of tocotrienols, vitamin E in general, of all the vitamins, because we didn't trust what our patient did with the capsules once they are home. So the simple capsule we are not happy with. So double blind, so it's a RCT properly designed. And we fed our patient with 400 milligrams per day, so 200 BCD. So we enrolled 87 patients, and the baseline biochemical, so the blood test for this patient were homogeneous, including alpha tocopherol, and the anthropometric parameters was also homogeneous, so the BMI and so on. So most of our patients, because of our inclusion criteria, did not have an advanced fatty liver. They were mostly mild. There were many mostly overweight and obese, and some of them had impaired fasting glucose. So after 1 year, we found that 8 in the placebo, 23%, normalized completely, compared to 15 or 50% in the tocotrienol group, in the mixed tocotrienol group. This actually reflects a bit the same results, even if not correct to compare to the PINC study. This is I don't want you to read all these numbers, but it's just to show you the plasma concentration of vitamin E with the alpha tocopherol and the tocotrienols. Just to tell you that the ultrasound results actually correlated with the use of mixed tocotrienols. Intention to treat analysis, so the dropout participants were calculated as non-responders, and we noticed there was a significant difference for advantage of tocotrienol, and the number needed to treat of this patient was 6. When we went to per protocol analysis, so the patient that actually concluded the study, we noticed that tocotrienols really have a significant hepatoprotective activity compared to placebo. In fact, we had a 67% improved, very significant. And of these 67, 50% of them were completely cured of the disease. So number needed to treat of patients is 3.8. This will happen on ultrasound for you to see. So this is a severe case. So you see the white here, this is the liver, and it's white. The white represents the fat. This is the kidney. And the echo discrepancy between the kidney cortex and the liver parenchyma is what the radiographers actually score. So what happened after 1 year? It became mild. As you can see, there is maybe you cannot see very clear, but it's much darker in this. So this part is more, is darker compared to the previous one. But still have some form of fatty liver. This is a patient severe. You see very white, the liver parenchyma very white. After 1 year, mild. This is what happened when a mild case, so a non-advanced stage. See, again, the liver, the kidney parenchyma, the kidney and the liver. After 1 year, completely cured. There's no difference in color, so you don't see white here is the same color, same black. So this is what we consider as cured. So this, in summary, was actually the 50% were cured when treated with the tocotrienol. None of them actually got worse, whereas in the placebo group, 2 got worse condition. There were actually, tocotrienols was very well tolerated. There was no adverse reaction. And there were no significant changes in major metabolic parameters. So we did not notice any major changes. The advantages of using mixed tocotrienols. Well, of alpha tocopherol, the recommended dose is very high, and we know the controversies. One point is actually that we make, as a scientist, we always make confusion, and with clinicians, we always, is that they tend to use for tocopherol the international unit, whereas when we talk about tocotrienols, we use milligrams, because there's no correspondence. So we actually, maybe this is a good opportunity to find an agreement also for this point. But 800 milligrams of 800 international units of tocopherol correspond to 560 milligrams roughly. Mixed tocotrinols, on the other hand, which have the same from palm oil, so the highest that we give in the 400 milligrams is actually gamma tocotrinols, and at the dose that we give, maximum is below 250, around 250 milligrams. So it's below the threshold of 400 or 800 international unit for alpha tocopherol, which is the controversy for alpha tocopherol. So to conclude, the take-home message for my talk is that fatty liver is very common and is a disease of growing incidence. It's potentially debilitating if you think about the transplant, and deadly for the consequences. Vitamin E has been indicated as possible treatment for non-alcoholic fatty liver, so we should work all together to actually strengthen the position of tocotrinols in these studies. Tocotrinols are shown to be effective, and this is for the industry boys. So the world market is there for you guys. Thank you very much.
Thank you, Dr. Magosso. I'd like to open the questions. Any questions from the floor? Yes.
Great talk. Thank you very much. Great talk. Just curious to know that population that you studied, how many may have been PCOS concomitantly?
Sorry?
If you know how many of the patient population looked at were PCOS concomitantly? Were polycystic ovarian syndrome. How many of the population studied also had that part of their history?
We found, because on ultrasound we also saw that there were quite a few, it was quite common, yes. But it was not sufficient